Good morning, friends. Dr. David Katz here. I'm a board-certified specialist in preventive medicine, public health, for those who don't know me. And I hope to do this somewhat routinely. I want to provide a COVID-19 reality check update. And I want to front load with the view from altitude. We do need to respect this virus. I've been to the front lines. I volunteered several shifts in an emergency department in the Bronx. This is the very bad disease in vulnerable people you've heard about. Respect it. The minute you stop respecting SARS-CoV-2, it will kill somebody you love. Don't do that. Don't make that mistake. The goal of our pandemic response should be total harm minimization, minimizing the harms of infection, and also minimizing the harms of indiscriminate lockdowns, which hurt people and kill people. So both of those matter. Any which way the pandemic hurts people is bad. Any way we save lives, help people is good. The best means to achieving total harm minimization from my perspective is a risk stratified set of policies. COVID-19 is not a one-size-fits-all scourge. It's a very bad disease in elderly people and people with chronic disease. It is overwhelmingly, not always, but overwhelmingly a very mild disease in generally young, healthy people. And the fact that occasionally it's a bad disease in someone who was previously healthy and is young, well, you know, everything in medicine is like that. We have outliers, we have anomalies, we see unexplainable bad things happen to good people all the time. I did 30 years of patient care, and I saw horrible cancers sometimes affect young, healthy people. I lost a friend, a colleague I worked with daily for 15 years, who had a perfect lifestyle, did everything right, and succumbed to cancer. So we can't always explain what happens in medicine, and there are going to be some outcomes related to COVID that we can't explain. So we have to accept that our, the correspondence between the data and our understanding of the disease will never be perfect, but in general, overwhelmingly likely to be a mild, often asymptomatic infection in young, healthy people, dangerous in older people, people with serious chronic diseases. As a quick aside, those serious chronic diseases, and I'm not sure I like to call obesity a disease, let's call it a risk factor, but obesity, leading risk factor for bad COVID outcomes, hypertension, dyslipidemia, elevated cholesterol, coronary artery disease, type 2 diabetes, and the CDC keeps updating the list of risk factors. Colleagues and I have published a couple papers about how prevalent these are in the United States. These are overwhelmingly preventable, fixable, reversible with lifestyle as medicine. There's an enormous opportunity in the midst of this crisis for us to get healthier as a nation, as individuals, as families. And the benefits of that formerly all pertain to long-term health, but they now also pertain to acute defense against COVID. Anyway, I hope to do these updates now fairly routinely, but the main reason I feel compelled to do it today is I keep getting these breathless headlines in the New York Times Daily about a record number of cases. I'm getting these breaking news alerts. And from an epidemiologic perspective, record number of cases means nothing if we have not been testing the same number of people all along, and if we've not had tests with the same level of performance all along. So if we're testing more and more people, and if our test is getting better so that we're more capable of finding disease when it's there, in other words, we have fewer false negatives, which is a huge problem with testing, and still is, well then, even if you just were testing the same number of people and the same number of people had the disease, if your test was better, you'd find more cases. If your test performance isn't improving at all, but you're testing more people and the disease is out there, you'd find more people. But if you're doing more testing and your test is better and the disease is still in circulation, of course your case counts are going to go up. Your case counts are going to go up even if there aren't more actual cases. But there are more actual cases too. So we are getting record cases every day for two reasons. One, we're looking for them more than we did early in the pandemic. We're looking for them with better tests, so this is called ascertainment bias. You're much more likely to find stuff when you go out looking for it, and in particular when you go out looking for it with a test that has some capability of finding it when it's there. So that's a big part of the record cases every day. U.S. sets new record, U.S. sets new record. Yeah, we're testing so much more than we were in the beginning. And by the way, we've never tested enough, and we don't need to do millions of tests. I've argued all along we need a representative random sample, 50,000 tests, but distributed all around the country, all different age groups, urban, suburban, rural, people with different health status, every zip code imaginable. Let's find out who has it, who's had it, who has antibodies. Out of that group, what percentage ever reported symptoms, what percentage ever needed hospitalization, what percentage ever wound up in the ICU, and which people. And who died, and what characteristics. And we've sort of been guesstimating our way into who is vulnerable, how many people, how many hospital beds, by cobbling together diverse data sources instead of gathering a systematic sample, which could be as small as 30,000, 50,000 people. The CDC does this kind of study with representative random sampling all the time. It's stunning and almost inconceivable that we'd be this far into the pandemic and not have done it. We haven't, but we are doing more testing. It's a bit haphazard, but we're doing more. And the primary reason for daily record case counts is in fact daily record numbers of tests. And so that's really important. Tests are better, we're doing more. We also do actually have more cases. Why do we have more cases? Well, because in the Northeast, in my home state of Connecticut, in New York City especially, we closed the barn doors after the horses were out. We now have very clear evidence that COVID was circulating in the United States, at least in January, probably in December. And in New York City, which is unique in that it's densely populated with a vertical population, so basically the number of people per acreage, if you will, is unusual in the country, and very high reliance on mass transit. So 60% of the New York City population rides the subway. So once the virus was in that population, pretty much everybody got exposed in very short order. That's why New York City got overwhelmed. There's a dense population of older people in northern Italy. That's why northern Italy got overwhelmed. And by the way, given what we now know from global data about the apparent mortality associated with SARS-CoV-2, it's clearly significantly less than 1%. It may be 0.1%. For healthier populations, it's lower than that, so a fraction of a percent. So in the United States, if you look at the total number of cases, the total mortality, it's still showing up as something like 2%, 3%, 4%, even up to 5% of people who get this die. That's just not true. What that means is at least 10 times more people have this in the United States than we've yet detected, which then immediately explains why if you go out and start looking for cases, you're going to have record case counts every day, because all along we had 10 times more cases than we were ascertaining, and we're finally doing the job of ascertaining them. However, we are also seeing that in parts of the country that are now having their first wave, and by the way, that's what's happening. So Connecticut, New York, the Northeast, we had our first wave, and it obviously hit us pretty hard, New York especially. But most of the country didn't have high viral circulation. This infection circulates pretty readily, a little more readily maybe than the flu, but it's not highly infectious. It's nothing like measles. So a lot of people who have what we might call casual exposure, they get near somebody else who has it, but they don't spend a lot of time together, they don't participate in a super spreader event, it doesn't get transmitted. So most of the country, whatever level of virus they had circulating, it wasn't enough to infect a lot of people before the lockdowns came. And so most of the United States did not experience a first wave. We are not seeing a second wave anywhere. We are seeing a delayed first wave. And by the way, this delay in a first wave was totally predictable and predicted. There's a piece on Medium entitled A Call for Honesty in Pandemic Modeling by my colleagues Maria Cecchina at the University of Pittsburgh and Wes Pegden at Carnegie Mellon. And they show if you just flatten the curve and don't have any particular plan for phase 2, the minute you stop flattening the curve, the virus is still out in the world, your population has no immunity, everything you thought you were preventing just happens on a different day. You don't actually save lives, you don't prevent hospitalizations. If you open up indiscriminately, in other words, if you don't have a really careful, thoughtful, meticulous, tactical phase 2 plan, okay, where do we go after just flattening the curve? If you just flatten the curve and then stop flattening the curve, you just change the dates. And that's exactly what we're seeing around much of the country now. I've just been looking this morning, and there are a number of data tracking sites I use, but the one I'm recommending, covidexitstrategy.org, which is overseen by Johns Hopkins University, which tracks the number of cases being reported by state, the 14-day trends by state, and I think really importantly, what's happening with hospitalization and ICU utilization. So again, covidexitstrategy.org, that's where I'm looking. And what it shows is that there are, first of all, we opened up around the United States haphazardly to some extent. We didn't, for example, do careful risk stratified reopening. Okay, we're going to carefully protect the highly vulnerable. We don't know yet that the water's safe. We're just going to put our toes in the water first, test it out, right? We're not going to just say everybody in the water, it's fine, don't worry about the riptides and sharks. We should have, but we didn't. So there's the reopening is haphazard. It should have been risk stratified. Young, healthy people out first. Let's monitor viral circulation. Let's see if case counts go up, because if they do, it means the virus is there waiting for us. We have to carefully protect the elderly, carefully protect people with chronic disease, and meticulously protect nursing homes, where, by the way, half of all the mortality in the United States has occurred. We could have cut mortality in the United States in half just with meticulous protection of nursing homes. And then we could have cut it by more than half by protecting more elderly people living at home, people with chronic disease. Anyway, risk stratified made sense at the start. It makes sense now. We should be doing it. But with relatively haphazard reopening, what we're seeing is two patterns. There are some states where denial, I think, runs pretty high, where people really just don't respect the virus. And again, I've been to the front lines. It's a mistake not to respect this disease. Stop respecting this disease. It will kill somebody you love. I'm warning you. Don't do that. Don't be one of those statistics. And the fact that you may not yet have seen a case up close and personal doesn't mean it's not real. You probably haven't seen a case of malaria either. You don't believe in it. You've never seen a case of smallpox. You don't think it ever existed. So, we all have to get over that. So get over that, because I don't want this disease killing somebody you love. And it's perfectly capable of doing exactly that. So the states that have high levels of denial, that liberate my state and we don't even believe this is a serious threat, they're not just opening up haphazardly. They're not being careful about the mingling of young, healthy people going to bars, getting coronavirus, interacting with their grandparents, or visiting their older relatives, or interacting with friends who have type 2 diabetes. And in those states, and there are a number of them, and again, visit covidexitstrategy.org and see the data for yourself. I don't need to tell you what they are, but in those states, hospitalization is going up, ICU bed utilization is going up, and deaths will go up. Deaths are going up more slowly, thank goodness, and that's for a number of reasons, including the fact that we've gotten much better at treating this disease. The advances in managing people with SARS-CoV-2 have been stunning. When I was deployed clinically, I saw them play out in a matter of days. The treatment protocols when I was in the Bronx were already markedly different from just a week before. That's amazing. I've never seen that in a 30-year medical career. And that's terrific, and it's a credit to all of the health professionals who are on the front lines. I salute them, my colleagues. Thank you so much for what you do. I was a drop in the bucket. I was there briefly. I came out of clinical retirement to pitch in a little bit, but the folks who've been there from the start will be there till the end. Thank you so much. It's hard. We all owe you a tremendous debt, but the treatments are evolving very fast. So far, thank goodness, we're not seeing deaths go up around the country, but there's a delay between people getting sick and then getting sick enough to die, so we may yet see that. I do not like trends in a number of states, Alabama, Arizona, Georgia, Texas to a lesser extent. I'm scanning through the list, but again, look at the data yourself, where we are seeing hospitals near capacity, ICU beds near capacity. That is not ascertainment bias. That is not more testing. So, and anybody who likes the argument we're finding more cases because we're doing more testing, yeah, up to a point. That doesn't explain more hospitalization. If you were sick enough to be hospitalized, we were going to find you with or without more testing. So if hospitals are strained, if ICU beds are filling up, that is because we are A, opening up haphazardly, and B, in some degree of denial about the dangers to older people or chronically ill people, and we're allowing them to get exposed. There's another set of states where I think there is also has been haphazard reopening, but where there isn't the complication of denial about the seriousness of the illness, where I suspect older people, people with chronic disease, are wary, and whether others are taking care of them, I don't know. I hope they are. Social distancing, wearing a mask, all of that. The young, healthy people who are saying, hey, time to get back to life, which I agree with. Maybe they're being careful about their older loved ones, but maybe the older loved ones are just being very careful about themselves because they are afraid of the disease, and rightly so. And so there are a number of states where the case counts are going up, and that's because of, as I said at the start, more testing, yes, better tests, and opening up, so more people are getting exposed. So there's a combination of finding more of what was out there all along, because again, we have easily 10 times more cases in the United States than we've detected, easily, at least that, maybe 20 times, maybe 100 times, but a lot more cases than we've ever detected. We're starting to detect them. They've been out there all along. But there also is more viral circulation. More people are getting it because we are starting to open back up. If that happens, and it is limited to young, healthy people because the practices and protections and policies are in place to very carefully shield the older people, people with chronic illness from exposure, then what you see is rising case counts without increases in hospitalization. And that's happening in a number of states. That's mostly happening so far in California. It's happening in a number of states. So again, go to covidexitstrategy.org, scan the list of states. They're color-coded. You'll see for yourself. But that's what's going on. So there's this dichotomy in the consequences of haphazard reopening. If you do both haphazard reopening, so again, you reopen without a clear plan of risk-stratified protections, and you have a population that is not respecting the disease, hospitalization goes up and people are going to die unnecessarily. So please don't be in the mix there, because I don't want anybody you care about dying from this disease if it hasn't already happened to you. And if it has, my condolences. And I've been affected by this. This has invaded not my innermost circle, but it's gotten pretty darn close to me. So don't let that happen to you if it hasn't. And if it has, I'm so sorry. And the idea that we can open up in a risk-stratified way and, in fact, let the virus circulate among young, healthy people, I'm fine with that. And this is may seem a bit radical, but almost every pandemic in history has ended with herd immunity. And rarely has that herd immunity been achieved with a vaccine. Usually it's achieved the natural way, where people who can safely get through the infection do, they're immune, and then those of us who've done that become the firewall that prevents transmission to people who absolutely can't get this disease because it's very likely to kill them. And the differentials there are enormous, orders of magnitude in terms of the likelihood of this killing healthy people under 50 versus people with serious chronic disease over 70 or 80. Massive, massive differences. So healthy young people under 50, certainly under 30, very, very unlikely to suffer severe consequences of COVID. Yes, it can happen occasionally. Yes, it will make national headlines because if it bleeds, it leads. The media are squeezing every possible drop of drama out of this. But the likelihood of bad outcomes in young, healthy people, very, very remote. We talk about school kids. I have a piece on Medium with my colleague, emergency physician, actually an expert in disaster response, Dr. Kelly Close, talking about schools and arguing that they can and should reopen, not because there's zero risk to kids. I'm a father. I have 5 children. They're grown now. But zero risk doesn't exist in the world. There is a certain non-zero risk of dying every day simply attached to living every day. Every day we're alive, we're at risk of dying of something. But usually those risks are low enough that we go about our lives and are not preoccupied with it. Well, if the risk of a child succumbing, and again, all things being equal, so there are kids with serious chronic conditions who should not be exposed to this. And again, we always have to be thoughtful, careful, and risk stratified. But given that, I'm talking about average, healthy 12-year-olds, the risk of getting COVID and having something bad happen as a result, we did the math, and you can see this on our piece. So again, it's Dr. Kelly Close together with me on Medium. The risk of a bad outcome from COVID is less than the risk of a bad outcome from riding the school bus, or frankly being driven by your parents to school. I mean, every day there are car crashes, sadly, in this country and around the world, and every day kids are hurt in them. And those numbers are substantially bigger than the numbers associated with COVID. So we've also, I think, gotten into this unrealistic mindset that since we hunkered in our bunkers, we're not coming out till the risk is zero. The risk will never be zero. The risk never was zero before the pandemic, after the pandemic, during the pandemic. Bad stuff can happen to us out in the world. It does every day, sadly, to someone, including children. But we need the risks to be at a level that is commensurate with the kinds of risks we take every day just by virtue of being alive and going about our business. The risks to school kids, for the most part, associated with this infection are less than the risks of simply going to school in the first place. So at that point, you say it's time for the kids to go back, assuming we have appropriate allowances in place to manage, okay, what about the teachers? What about administrators? What happens when they go home? Do they have elderly relatives at home? Is there a risk of transmission there? All of that needs to be managed. It can't just be a haphazard, lock everything down, liberate everything and everyone. And that unnuanced thinking, this either-or mentality, has proven enormously costly, and it's one of the many reasons we have mismanaged everything about this pandemic. I'm working on my next column. I'm going to go into the details of why we so badly mismanaged every opportunity in this pandemic, and we absolutely have. A couple other things quickly. There's been lots of debate about masks. Yeah, masks help. Whether or not we have decisive, empirical, randomized exposure evidence that masks help, it just makes sense that they help. When we talk, I'm talking now, spewing water droplets into the air. If I had virus, it would be in those water droplets. If 90% of those water droplets are trapped by my mask, I'm putting less virus into the air. Less people will get exposed because of me, less people will get sick. It just stands to reason. So, one of the mistakes, I think, with science is the idea that if we haven't done a randomized trial, we can't take sensible action. No, not true. So, yeah, science offers us the power of a freight train to drive toward truths we can't otherwise get to. Sense lays the tracks. If you've got the train and no tracks, you get a train wreck. If you've got tracks and no train, you can walk along them. You'll get there eventually, but it's really slow. I like the combination of tracks and train, in other words, science and sense. And what sense says is do the sensible thing while waiting for the science. Sensible thing is wear a mask. Wear a mask to protect other people, wear a mask to protect older people, wear a mask to protect vulnerable people, and in those states that are opening up, part of the strategy of risk stratification is when younger, healthier people who may or may not have this thing are interacting with people who can't get this thing because they're vulnerable to severe cases, wear a mask, social distance. We do need to protect one another. So masks make sense, and the science we have, yeah, sure, it's nascent, it's not decisive, it's evolving, but so what? Let's use sense while waiting for the science, and then let's see how the science catches up. And we had definitive studies to tell us masks are useless. Okay, then we were wearing masks for nothing. That's not going to happen, by the way. Much more likely, when we have definitive science, it will say, yeah, wearing masks was a good idea, and then we'll be glad we did, and those of us who didn't will have been proven wrong. So, get on the right side of this. There's also been a lot of debate lately about this being airborne. And I honestly don't understand why the media is making hay with this. Of course it's airborne. We knew that it's exactly what this contagion was from the start. We knew that SARS-CoV-2 spreads through the air. So all of this breathless debate about, airborne, believe it or not, it's actually just about the size of the water droplets. So, when our saliva gets in the air, it's either big enough to be called a droplet or small enough to be called vapor. And the debate is about how much of the virus is in the vapor, the smaller droplets versus the larger droplets. Is that really the basis for headlines all around the world? I honestly, this one mystifies me. I don't understand the preoccupation, other than, sad to say, what has clearly been a desire by the media and all of us in social media to milk every possible drop of drama out of this situation from the start. But yeah, of course it's airborne, and of course it can be, the virus is smaller than any water droplet, so of course it will travel in the larger droplets we call droplets, and the smaller droplets we call vapor. Duh. I mean, I just don't get the debate there. So then the only issue becomes back to do masks help? And, can this circulate in the air for a while? Well, we've had evidence all along that it can circulate in the air for a while. And we've had evidence that masks are not perfect because they catch the larger droplets, not the smaller ones. But again, so what? The transmission, all at the same time that there's been all this debate about water droplets versus airborne and vapor, we've also been hearing that almost all the transmission is occurring in super spreader events. This, to me, just a quick aside, this to me is a little bit like debating a small constituent of a food. Is it good or bad for us, when we already know that the food is good or bad for us, right? So, if there are lectins in beans and lentils, and we worry, could lectins be bad for us? But we already know that people who eat beans and lentils more often have monumentally better health outcomes than people who don't. In fact, it's a staple in all of the world's blue zones. One of the most salient features that unifies those very different diets is lots of beans and lentils. Well, then, finding some one chemical compound in beans and lentils that could conceivably, hypothetically, be bad for us when we already know that they're good for us, that's a who cares conclusion. Similarly, if we already know that the actual transmission of the virus is mostly super spreader events, where people are singing together shoulder to shoulder, spewing both droplets and vapor into the air in close proximity for an extended period of time, and casual passing in the street, brief conversation, almost anything outside in sunlight doesn't result in transmission, that's massively more important than the pseudo debate about the size of water droplets. I'm sorry, I really don't get this one. Maybe some colleagues will react to me, and I'm sure there'll be comments that rebuke me for almost everything I'm saying here. What else is new in social media? But I honestly, as a board-certified specialist in preventive medicine, public health, who has co-authored multiple editions of a leading epidemiology textbook, formally trained in epidemiology, I don't get it. It seems like we're debating how many angels can dance on the head of the pin. It's transmitted through air, of course. Every size water droplet can do it. But the fewer water droplets we put into the air, the fewer viral particles we put into the air if we have the disease in the first place. The fewer viral particles, the lower the dose. I have another column on Medium with my colleague, Dr. Daria Long, and we talk about the importance of dose. One of the things that wearing a mask will do is, it'll eliminate the risk of transmission. It'll massively reduce the dose. Why does dose matter? Let me give you a quick analogy. Let's say you are defending a compound. You have a modest-sized security force, and you are assaulted. And assault A comes from a small, haggard band of enemy with bad weapons, and your security force repels them so easily that you didn't even know it happened. Your compound's perfectly fine, totally unscathed. That's scenario A. Scenario B, the assault is by a group that's as well armed as your security force, about the same size. Once again, you repel them. Minimal damage to your compound, but some, but you carry the day. No serious or lasting harm done, but you were certainly aware of the assault. It was scary. And then scenario C, once again, your compound is assaulted, this time by a force that is massively superior in numbers and armaments to your security force, and sadly, you are overwhelmed, badly damaged, and you either survive or don't. Well, that's what a viral assault on the body is like. The compound is our body, our security force is our immune system, the enemy is the virus. So if you're exposed to a very few viral particles, you basically repel it before your bloodstream ever even sees the pathogen. This is why, by the way, some people actually get to immunity to SARS-CoV-2 and don't show up on our antibody tests. The antibodies we test for are the long-lasting, if you like the term deep antibodies, the ones that indicate bloodstream exposure, essentially, IgM and IgG. If you have a very superficial infection, that scenario A, your compound assaulted by just a few haggard enemy, you actually repel the virus just with what's called secretory IgA. We don't test for that. That occurs in the nasal passages, mucous membrane, surface of the body. So that's where our compound's been assaulted and we barely even noticed it happen. And if you have a trivial exposure to SARS-CoV-2, you actually can become immune in that fashion. And by the way, the issue of immunity, permanently immune, who knows? But partially immune for now, absolutely yes. Do we have any evidence of people getting this thing twice? No. Is there reason to believe people can get it twice? Well, maybe eventually. You know, you can get the flu more than once because the flu changes over time. Same thing may happen here. But is there any reason to think that in the immediate recovery phase from SARS-CoV-2 you can get SARS-CoV-2 again? No. And so far every report of that possibility has been refuted when all of the evidence is available. People have not gotten it twice. It was a false negative test followed by a true positive test, that sort of thing. So every reason to believe that with this infection, like every other infection, that after you get over it, you have at least partial immunity for at least some period of time. So relax on that topic. But you can get to immunity with secretory IgA that we don't measure. You'll show up negative on an antibody test, but you've actually already had this infection and gotten over it. And that's when you get very limited viral exposure. Scenario 2, or B rather, where there's a significant assault on your compound but you prevail, well, that's a symptomatic infection. You will then make IgM, IgG, but again, moderate exposure dose. It's scenario C where you're in big trouble, almost no matter who you are. So we've all heard reports of young, healthy professionals who have gotten really sick or died from COVID. And as I said earlier, this is not a one-size-fits-all threat. It's a dangerous disease for elderly people, people with chronic disease. It usually is not for young, healthy people. But all of that changes if you're a young, healthy person doing intensive care and you know, ventilating people with this infection, or doing bronchoscopies in people with this infection. I mean, essentially every day of your clinical care is a super spreader event, multiple times a day. So now you're not just getting exposed in ways nobody else gets exposed, but you're getting exposed to doses nobody else sees. And so you have a perfectly robust compound, you have a perfectly robust defense force, security force, but you're being assaulted by a massive army. And that can overwhelm any compound and any security force. So some of those headlines about young, healthy doctor or nurse dies, tragic. Again, my condolences. Where I worked for a little bit in the Bronx, there was a beautiful photo up of a nurse, just a lovely face, and obviously much loved by her colleagues there, who had died of SARS-CoV-2. Young, don't know her health status, but let's assume it was pretty good. It can happen. Rare, but it happens, in each instance is a tragedy. But one of the reasons it can happen to health professionals, and we're hearing those stories in the media, is the exposure dose. Exposure dose matters. So we can manage our exposure dose with social distancing as appropriate, the mask use, which will cut down aerosolized transmission. I don't really understand the debate about vapor versus droplets. We put both into the air, and if we trap the droplets with a mask, and if we minimize the potential exposure to vapor with social distancing, the number of viral particles in the air will be reduced, and the number of people who get sick will also be reduced. The only place this debate becomes relevant is in crowded working conditions indoors, where obviously people occasionally take their masks off and they have the virus. It'll get into the common air, the shared air, and it's conceivable that the cumulative dose of virus in the shared air, if it's recirculated, can make a lot of people sick, and you have to worry about places like prisons, and you have to worry about places like meatpacking plants, and on it goes. But those are super spreader events. You know, basically, you know, situations where you have people potentially with the virus in crowded conditions, working indoors and on. So, you know, what do we need to do about that? Well, those are places where Either they can't open until viral circulation is near zero, or everybody who works them needs to be tested and cleared before they work there, or we need everybody there to carefully wear the best personal protective equipment, or we need to adjust the working conditions so that social distancing can be practiced, or we need very careful disinfection protocols addressing the air and surfaces. And the right response actually would be all of the above. Some systematic approach to risk minimization in conditions where, okay, if this is a job that has to be done and people working here are going to be potentially exposed to the virus, we need to do everything possible to make sure only people who can most safely get the virus are here. So people with serious chronic disease can't be here. We need to allow for that. We have to offer waivers. We need to disinfect the air, we need to disinfect surfaces, we need to social distance, we need to use PPE, and we can then reduce the risk to very low levels. But you know, the debate about vapor, I think, has become yet another thing for people to worry about. Oh my God, I can get this in ways I never thought I could before. No, it's really a debate from my point of view about best mitigation practices for shared indoor air. And okay, that's a reasonable discussion to have. But again, we already knew about super spreader events, most of the transmissions there. Okay, this is enough for the first of these videos. I'll try to do these periodically. But just to wrap, I thought at the beginning when I published my opinion piece in the New York Times, and I think now, we should be aiming at total harm minimization. The infection can hurt and kill people. 40 million unemployed can hurt and kill people, and we're seeing evidence that it is doing exactly that, mediated by domestic violence, elevations in crime, desperation, food insecurity, hunger, addiction, depression, suicide. All of that has increased. And over time, the cost of 40 million unemployed will be higher. My colleague at Stanford, Nick Bloom, a health economist, has made the mathematical case that the total number of years, person years of life lost due to 40 million unemployed has the potential to greatly exceed the total number of person years of life lost due to the infection that we've seen, even with over 120,000 deaths from the virus in the United States. Both of those are bad. Both of those matter. This is not about lives versus dollars. These are lives and lives, and our goal should be total harm minimization. The right approach to total harm minimization, which we've never yet practiced in anything resembling a sensible way, is vertical interdiction, risk stratified interdiction. The protections required for nursing homes absolutely need to be perfectly meticulous. The protections required for older people, people with chronic disease, need to be robust. And frankly, young, healthy people can mostly safely get through this. Not every last one, because being alive puts us at some risk of dying, but it's overwhelmingly a mild infection in young, healthy people, and all the more so now that if you do get severely sick, the treatment protocols have gotten massively better. The vaccine story I'll revisit another time, but the idea that we can hunker in our bunkers and wait for a vaccine, I think is misguided. We have no idea what the timeline will be. It's way too early to predict when we'll have an effective vaccine. Effective, safe, mass-produced, universally distributed, affordable to everybody, and there are a lot of hurdles in that race to get us to the point where we are all immunized against SARS-CoV-2. And I think, given the levels of viral circulation, almost inevitably we will have made our way to herd immunity, whether we wanted to or not, between now and the time we get a vaccine. So since that's happening anyway, let's manage it, because otherwise this pathogen is mismanaging us. So more to follow. My first installment of COVID-19 Reality Check. I'm Dr. David Katz. Stay safe. Have a good day.